I'm here with Shane Shepard. He's the head of RCM at Anagram. My name's Steve Alexander. I'm head of growth at Anagram. The purpose of this conversation is to have a deep dive into some terms that might be unclear, might need a little bit of defining, and we've got the right person here to help define it. Shane, how you doing this evening?
Good, man. It's good to continue this conversation. This group of people, it was very enjoyable last time, and so it's an honor to be speaking to many of them again and to be with you. And I'm looking forward to it. Yeah.
As am I. As you folks are dialing in, thank you again for joining. Thank those of you who came in a little bit early. We love to see that kind of excitement. There is a poll live that I appreciate all of your answers for, and we'll dig into those as we go forward. As you're dialing in, if you could drop where you're calling in from in the chat, and then also take this opportunity to invite you to ask any questions you have. Medical billing related, vision billing related, general insurance questions, anything that you'd like to ask, anagram related questions. We're here to answer all of those and have hopefully an engaging conversation. All right. Shane, any words of wisdom before we dig in?
Words of wisdom. Let's see. If you don't code it, if you didn't put it in the chart, it didn't happen. That's kind of that's an axiom that always follows in coding and billing world. If you didn't document it, it didn't happen.
Absolutely.
I don't know if that's what you're looking for. That's not Confucius say, but
Yeah, listen,
it's what I
think
got.
that counts as that's specific wisdom. I think that's better for the audience here. We got folks dialing in from Pennsylvania, from Florida, from Wisconsin, from Central New York. And earlier we had folks who dialed in from Providence, from Grass Valley, California, from Brooklyn. As I said, we are all over the map today.
It's wonderful. Some Wisconsinites. I love Wisconsin. I believe Wisconsin is the most northern state.
Is it because of all the cheese? Is it because it's
Is
all
the
cheese?
cheese and like there's just the content of the type of people there I bond well with. But
My wife's from Wisconsin.
oh, there you go. There you
Yeah.
go.
Yeah, we were just up there actually having cheese.
I've never met someone from Wisconsin I didn't like. I'm
Oh,
sure they're there, but
yeah.
um, I've never run into them. So anyway, it's good to be with everyone, and I know there's different time zones across. So y'all giving up your time, so let's make it meaningful for you. And yeah, if you have things that you really want to know, that's what we're here for. And so Steve and I are going to talk about some terms, but we're here to help you and to be there for you. So if you have things you want to talk about, let's talk about them. So
Excellent. Yeah, thank you, Shane. And also, I did put in the chat a little bit earlier my email address and Shane's email address. It's steve@anagram.care or shane@anagram.care. So if there are any questions that spring to mind after this session or during the session, but you don't want to ask, if you want it answered publicly, feel free to shoot us an email and ask whatever questions you'd like. And then, yeah, we can dig in. We have more folks from Virginia, from Kingston, New York, from Wisconsin. Lots of Wisconsin folks. It's so fun to see. Welcome, everybody.
well, that was
All right,
fortuitous. I did
Shane.
not know that.
Yeah, it was a good thing you said nice things
Yeah,
about Wisconsin.
yeah, go figure. All right, hit me, Steve. Let's go.
All right, all right. So there are a lot of things that we covered in the last session, but I think it's worth digging in to give a quick overview of some of the things that we addressed last time and then dig in that context. So
All right.
first things first, I think a lot of billing questions reside around denials and rejections. So in a sentence or two, what are denials? What are rejections? How are they different? And how do you address them?
Okay, we'll level set here. So the
Yeah.
rejections are the claims that didn't get in the front door. They weren't accepted for processing. Okay, so if a policy number was wrong, let's say, and you submitted that claim, it would get rejected. There's no way it could actually get processed because they couldn't identify the member, right? So that's a rejection. And a denial is one that's accepted for processing, but didn't merit payment, right? Didn't process. So let's say that you had a corneal diagnosis for a retinal procedure, right? Then that would deny because it's not, they don't drive each other. It's important. It's a very important distinction and one that a lot of people don't make. They use those terms interchangeably, synonymously. But a rejection was never accepted for processing, right? And so the timely filing on that rejection is the clock's still ticking. The original clock is still ticking on that. And so you need to address those in a timely manner. If you get to those well after the fact, and some of these health insurance companies have very short timely filing deadlines. United Healthcare, Humana, I think in 90 days and 120 days. So as opposed to say Blue Cross Blue Shield, Medicare can be 6 months to a year. So if you're a little slow getting back to it and recognizing that it was a rejection, and then you get it fixed, you get the date of birth corrected, the policy number corrected, and you submit that, well then it's going to it can potentially deny for timely filing. So it's an important distinction in the priority of working it, because once it's accepted for processing and denies, a clock starts over. It may be a different clock, it may have a different time frame, but now the clock starts over. So you have a little bit more leeway with that. And the manner in which what you have to do to resubmit that claim. So the rejection, it was never accepted for processing. And once you correct it, you submit it as an original claim, because it is an original claim, and then it's processed. If you do the same thing for a denial, it is not accepted. It is a duplicate, right? Because you've already submitted it. So you have to refer to the initial submission. And you do so in box 22 with a resubmission code of 7. You can use 8 for a void, but 7 is a corrected claim. And then you would also place the claim control number or the internal control number, the ICN or CCN, in that box. And it would be accepted as a corrected claim and not denied as a duplicate. Steve, that was not 2 sentences. I apologize.
But I think it was a good, thorough answer to that question. I really appreciate it. I think valuable to level set. So let's dig in a little bit further. I think there is a circumstance where maybe a claim isn't denied or rejected yet, but there's information missing. So when we're processing claims for our clients and we run into missing information, what do we do about that, and how do practices avoid running into that problem?
Yeah, that's a great question. So there's in whether you're using us or using a clearinghouse, it's important who is rejecting your claim, right? And so there are different stops along the way. And so whether your own, let's just use the practices themselves, and they have a biller and they review the claim and they go, nope, this is wrong, right? Before they've submitted, they in a sense have rejected the claim, right? There's nope, I'm not going to move this forward. I need to go get XYZ. And so the clearinghouse is another example of that. The clearinghouse may reject a claim prior to it going through to the payer, and the path for everybody who may not be in the know about these things is that, you go from the payer generally on health-related claims, you're going, and some managed urgent care claims, to the clearinghouse, and then the clearinghouse submits it to the payer. And so I'm talking about like the policy number being wrong, the date of birth being wrong. Only the payer would know that, but Steve makes a great point here in that the entities in between there may be checking for the presence of data, maybe not the validity of the data, but the presence of the data. And so maybe if you didn't check a box, and there was something in the formatting incorrect, they may reject it right there. And so you could have to go get that information prior to it actually being rejected by the payer. Was that as clear as mud?
So yeah, no, it's a great answer, and I wanted to highlight that part of what I've noticed as we've dug more and more into the billing conversation is there are so many steps along the way where there's other opportunities for mistakes to happen, or for an insurance company to reject the payment or deny payment to the practice. And I think one of the most valuable things we can do at this time is highlight for practices that are maybe pretty new to billing or want to get more into billing, how to avoid the things that cause that kind of frustration. That's why I wanted to start with rejections, denials, and missing information, because those are the things that kind of cause heartburn in practices.
Yeah, and it's just a general rule of thumb that the older the claim is, the less payable it is, right? The older it gets, probably the more things that are wrong with it, the less chance you're going to have to get it paid. So the more you can scrub a claim, whether it's visually, whether it's with clearinghouse software or something like we use, you can scrub the claim, get it through to the payer clean and get it processed right the first time so you don't have a denial. And so for us, let me just kind of shamelessly pitch what we've done. We built, in order to reduce error, we built a scrubber, right? And so we take all the things that we know about the claims. And yes, we impart that to our employees who are looking at their claims prior to submission. But I think all the business owners out there can attest, you have varying skill sets. Not every employee has the same skill set. It's just a fact. It's not a comment about any employee. And so we take all those rules and build it into some functionality, a little module where we can take the claims, push it into, and all the rules be applied uniformly across the board. And there are varying ways to do that. We've built our own custom version of this, a scrubber. But clearinghouses also scrub. So if you're using a clearinghouse, it's inherent that they're scrubbing it. But they're scrubbing for and looking for the presence of data. And then it's incumbent upon you to code it correctly and the modifiers and all of those things and have that correct. And there's a lot of payer specific rules that the clearinghouse just is not going to know. And it's either your biller or someone like us that has that knowledge. And then we try to build a lot of that into our scrubbers so that we can catch those things that are payer specific, procedure, even client specific. If you had someone who is credentialed as an individual with one payer, but with a group with all the rest, we can flag our systems to catch that stuff and send it out properly. So yeah, so all of you are scrubbing to some degree. It's just to what degree?
We have a question from the audience, actually. I think it's a great one. It feeds right into it. How did you build your own scrubber?
They brought me in here and just kind of hit my head until all the information came out, and then there's these talented people here that really all the skill sets. So there are a couple of things. We talk about how the rules are ambiguous. There's a couple different ways to get information, right? There's the School of Hard Knocks, just going through it and doing it, and there's something to be said for that for sure. And that's how most of us get our knowledge there, including myself, just experience. But there are guidelines, and some of you may be familiar with LCDs and NCDs. LCDs and NCDs are the rules that CMS has put together for a particular code, the frequency of testing, what diagnosis codes drive it. Now, those are CMS rules. Now, each payer has medical policies. The policies that they apply to their terms, to their procedures, and to the policies that they write, right? And those are out there. They're just not in a form that's easily consumable, right? And so then people don't even know that they exist, but they are out there. And so you've got that. And then we talked a little bit about this last time, Steve, the feedback loop. And so whenever you're processing claims and you're getting rejections, you're getting denials, when you get that information, that is food for your scrubber, right? If you're taking that information and you're able to deal with it, and it's not overwhelming, and you take that information and go, okay, when I see this procedure and this diagnosis for this payer ID for this particular payer, then it denies is not medically necessary, for example, right? And so you can take that information, feed it back into your scrubber. For us, like we have the initial submission, right? So it has the payer ID, it has the diagnosis codes, and it has the procedures, right? And we have sophisticated software developers that can take and go back and cobble all this information together, right? So we have the submission that has all that information. We submit it, we get a denial. It says, no, nope, not today, not this combo. Well, that's a rule, right? That's a scrubber rule. And so if our developers have built a lot of functionality to take all the information that's continually being given back to us and turning it into rules to prevent future rejections and denials, really.
Yeah. Well, I think that's a super thorough answer. In a nutshell, Anagram's a software company.
Yeah.
What we do is we build digital tools to solve insurance problems. We've been doing it for over a decade with the out of network solution that we've had. A couple of years ago, we added in network eligibility verification and universal search. Universal search, for those of you who don't know, that's when when a patient calls your practice and says, "I have a vision plan. Can you tell me what it is?" And it's a crummy situation to be in because your options without universal search are pretty poor. But what universal search will do is you put first name, last name, and date of birth into Anagram, and we will search every vision plan all at once and surface to you whether they're in network with VSP or out of network with IMED. However your system is set up, we will search that way and surface that information. And one of our attendees here, that's her favorite part of Anagram. And genuinely, I love it too. It solves so many problems and saves so much time. Thank you, Michelle. But when Shane joined Anagram a couple of years ago, the goal became really, really clear. We wanted to build solutions that made the genuinely much more complex, much more prone to rejection, much more frustrating element of our industry into a digital scalable platform. And we're here not to pitch Anagram, we're here to provide education. But the answer to the question of how we built the scrubber is leveraging Shane's decades of experience and building it into a robot. Decidedly less charming, the robot. No Southern charm. That robot never says fixin'. But the scrubber is really talented at fixing it in such a way, conveniently, that the claims go through and the payments come in faster. Awesome. Question from the audience: how is this different from TriZetto/Gateway?
Yeah, from on my side of the house, the services part, it's just that it's service. And so TriZetto, Gateway, Cognizant, the parent company, it's software that someone is using at the practice, right? And limited software, I would say, compared to what we built, but it's software and it's a great question, and thank you for answering it, Marcy, asking it. So a lot of times people don't understand the distinction. So the hokey analogy that I use is that there's a hammer and a carpenter, right? And so you can go buy a great hammer at Lowe's, right? Somebody's got to pick up the hammer and use it, right? And so TriZetto makes a fine hammer. The piece of software that you use as a conduit to the payer, right? Somebody has to know how to use that thing, right? Somebody has to pick up the hammer and build the house. And so that's, I would say, the primary difference. Now, we've built our own hammer, and we leverage clearinghouses, and TriZetto is one of them. And so we take their pipe, essentially, their path to the payer, and then we built a lot of functionality around it to be master carpenters. So I went in and out of a terrible analogy, but long story short, let me take one more swing at this, Steve. The TriZetto is a piece of software that you would use to manage this process, and it lacks specific functionality to help you to do that. Our service is both the software and the service. We go into our practices, we remote into our practices, export the claims, scrub them, submit them, work the rejections, work the denials, post the payments. We're doing all those things. And as opposed to TriZetto, who would give you a piece of software and it's up to you to do all those things.
Yeah, I think another key difference is that while TriZetto, like you said, Shane, is just a software that you have to learn how to use, how to become an expert in. And over time, over many rejections and maybe taking some courses and so on, you'd learn how to use TriZetto more effectively. But TriZetto won't teach you how to be a better biller. Anagram, through courses like this, through our webinar series, through our blog and from your account managers, we will teach you to be a better biller. And not, just out of altruism, although we do think it's important to give back to the industry. When you're a better biller, our business is stronger. It makes it easier for us to help your practices lower your administrative burden and see more revenue.
Yep. Well said. We got a couple good questions here that are right into our, so I'm happy to talk about them.
Yeah, let me pitch them to you, and then we can
Okay.
go. I'm
Okay.
going to go in a slightly different order. Marcy will get back to your question in just a second. From Christina, do you do both medical and vision claims?
Yes, we do both medical and vision. Our clients don't have to do both. They can choose to do medical, medical claims only. A lot of times people, they hire us for different reasons. If there's a lack of labor, they'll hire us for the vision, right? You probably have knowledge of how to do the vision, but you may have a lack of labor. Maybe the employee pool in your area is really shallow, and you don't have enough. So you can hire us to do the vision, usually for that reason. On the medical, it may be our expertise in these areas, and so we do both. Our clients can kind of pick and choose medical, vision. Some clients choose, they want medical billing, but then they just need help posting their vision payments, right? And so we do that. So we try to build our offering in whatever way is best for our clients. So we do both. One of the great things, if you do both with us, a lot of claims deny for non-covered services to medical plans. When you bill a routine eye exam to a medical plan, but they don't have a preventative eye exam covered. Well, if we're doing both, well, then when we get that denial, we'll switch it over and bill it to the vision plan, and you won't have to deal with it and not lose that revenue. So we do both medical and vision.
Yeah, and part of what Shane said there that I think is really important is we will customize the offering and services to what you need. We understand that there are practices at different levels of billing expertise and volume, and that requires kind of a different level of service. If you're primarily vision and your medical is just growing, that needs a different kind of approach than if you're, full steam ahead medical billing, and or if you're primarily cash pay. So we take all of that into consideration and have tools built to support you wherever you are, which is, I think, a really important question. Thank you for asking that. I'm going to go down a couple more questions here. Shane, what are your top 3 KPIs for evaluating the effectiveness of your accounts receivable management process? Thank you, Amy.
Okay. So KPIs, key performance indicators, and that word is key. There's a lot of metrics, but we measure a lot of different things. So the ones that come to mind obviously are denial rate. We want an ever decreasing denial rate, speed of successful submission, and so that's how fast are we getting to those denials. And I would say speed of inquiry response. So there's a give and take with our clients when there's missing information and going back, and we want to make sure that we're addressing those things. There's a number of other things as well, first pass rate, but those speed of successful submission, denial rate, inquiry response, those are the ones that top of mind.
Excellent. All right. We got a question from Tim. It's an Anagram specific question. For a larger practice, do you replace our billing department by accomplishing medical/vision claims? Are you small business oriented only?
Yeah, so generally, there's a need for a champion at the office. We kind of supplement the business's own labor. There's always going to be a need to go back to the patients and ask, policy information, things of that nature. Go back to the doctor and get more specific diagnosis codes. But if someone outsourced both, the whole shebang, both submission, rejection, denial management, payment posting for both medical and vision, then it reduces the amount of labor that's necessary at the office substantially. But there is still a need for some champion at the office. But a lot of times people, they have a really good employee. The business has just grown and they need somebody to, and or they need to need to take that person and utilize them in the way that's most effective for the business, and maybe be more patient facing. So if you've grown and you can't find the right person, you keep training them up and then they quit, or you want to take the person that or people that you have and put them where they're most effective, dealing with the patient, being patient, face forward, then we're good. We're a good option to bring into. I would humbly submit to you. Yeah. Steve, you asked if I can go back. You said so this turned into all about us, and so I wanted to be all about them. But thank y'all. The when we do medical and vision for people who use our other product is obtaining out of network benefits and submission of out of network claims. A big part of it, anyway. Steve can speak more to that. If somebody's using that product and this product, then we'll go submit those for them, right? There's no need for them to have to go take the data from one system and put it into the other. And so that's also a benefit of using our billing service, is that if you use this other software, then we can put it together and take more burden off of our clients' plates.
Excellent. Yeah, I think there are a couple of points that I'd like to touch on. So to your question, Tim, about whether or not we'll replace your billing department, I think Shane's point is extremely well made. We will act as a supplement. Think of it as hiring Anagram to be an expansion of your billing team, where we still need somebody on site who knows what's happening, who can answer questions. I think it's actually a really important way to transition into our inquiry tool. So we recognize that outsourcing billing is a daunting proposition for a lot of reasons. What some of the horror stories that we've heard from other organizations that do this is that they throw a lot of work back onto the practice. So the practice will put in the information, the outsource company will come in and check for whether or not they can file a claim. And if they can't, they throw that work back onto the practice, and then it just sits there. It has a tendency of getting lost or going unaddressed, and time goes by. And then suddenly, to your earlier point, Shane, about timely filing, we lose days, and the longer it waits, the less payable it is, I think you said. So our inquiry tool allows a practice to ask questions directly of our account managers and vice versa. So if we get an invoice that we can't process because information is missing, or a claim got rejected or denied, or somehow we need to communicate with the practice, we create a task that where notification goes to the practice for them to address that concern. One of the benefits of doing it this way is that the task doesn't disappear until the account manager has thoroughly addressed the inquiry, and which means the claim has been submitted, which means money's on its way to you. So really, really important distinction.
Yeah, I'll just elaborate just a little bit there, Steve. We, our billing service, and we can transition in here in a bit, but our billing service really is to reduce burden. The value is to reduce burden and increase revenue, right? So when things reject or deny, if we just throw those back and pitch those back to our clients without putting some thought into it, then we're not really reducing burden for our clients. So we do everything we can to not ask our clients unnecessary questions, dumb questions. Let me be blunt, right? So if a claim rejects for the policy number, but the card is scanned in, we should go find that for our clients. We shouldn't pitch it back to them and go, hey, go find the policy number, all for them to pull up a scanned copy of the card and go enter it in, right? So we do have an inquiry tool to go back to our clients, but we have a kind of a vetting process internally to review these questions before we ask them of our clients, so they don't get head shakers, So it's an important piece of this. And if any of the audience has used billing services in the past, I'm betting you they can relate to that. Yeah. All right.
All right. Now I'm going to dive back to Marcy's question, and then we'll get back into terms. So Marcy's question was, how much is Anagram?
So our business model is that we take a percentage of what gets paid, and so copays don't count, Deductibles don't count. Chargebacks don't count if you're in network with a managed vision care. Did you get a check? Did you get paid? If you did, then there's a percentage of that that comes back to us. The money goes to our clients, and then they get an invoice for a percentage of that. That percentage is 6%. So and then so the other thing that you should know is that we supply the clearinghouse. So if you're using TriZetto or some other clearinghouse, we pay the bill for that. And you still get access, but we cover the bill for that. So your TriZetto bill goes away, and it's a percentage of what gets paid. Other billing companies, if I may say, kind of twist this a little bit, and they'll flip the sign on the chargeback. They'll include the copays, deductibles, things of that nature that you didn't actually get paid. So our business model is to have a vested interest in you getting paid. So if you're rendering a bunch of services that go to deductible and you're not recognizing how they go to deductible, it's incumbent upon us to be your partner and help you with that, right? To the extent you want it, right? We're not trying to interject and run your business, but we do want to help you when you want the help. And so that's a key piece of our business model, and kind of the MO is that we're all kind of in this together, and we have mutual interest in you succeeding.
Excellent. And then on the open access side, what we call open access, which is the vision eligibility verification and out-of-network claim submission with universal search, it's about $300 to $400 a month, depending on the term. But if you think about it in terms of capture rate and generating revenue, if you capture any one patient that you otherwise wouldn't, Anagram pays for itself every month. We have practices across the states that are submitting literally dozens of claims to vision plans on an out-of-network basis every week. We also have published a lot of resources, an entire ebook on how to step away from vision plans and when and why it makes sense and how to do it successfully. One of the great things that we get to see is when practice joins Anagram and does the out-of-network eligibility piece. Over time, not only do we see their out-of-network volume grow from the vision plans they're already out of network with, but over time we see them step away from more and more plans. One of the key methods for practices to do that is to get really good at having this conversation, being able to talk to a patient about why we are an open access provider, what it means for you, and how we can help you leverage your benefits here while providing you the kind of service that we want you to have, that we believe you deserve. And another thing that everybody should know, if you go to our website, goanagram.com, and there's a pricing page where all of this is laid out for you. You can see our prices across the board. You can fill out if you have a question, book a demo. Another kind of key component of us, despite us talking about Anagram a lot in this session so far, we are not a pressure organization. We want the clients where it makes sense. We're not looking to force anyone down any particular path. Our best clients are the ones that understand what we offer and work with us as a partner.
Steve means that, and I think you can see I'm uncomfortable talking about it so much. I'm used to talking, making me like, ugh. But so I want to go back, Steve, if I made Amy's question. She asked about top 3 KPIs. And there's one I kind of breezed through, and that's speed of successful submission. And so I'd like to kind of go back to that and give her a little bit of meat there. I didn't give her enough. So Amy, speed of successful submission. So there's the denial rate. How many, what on a line level and a claim level, what is what's the rate of denial, right? The speed of successful submission. So how quickly are you getting claims to actually process, right? So some are going to deny, and you need to go work those, right? So if you never worked a denial, let's say you're filing your claims all the time, and you never worked a denial, your speed of successful submission would be super low, right? Maybe it's a number of a matter of 2-3 days. because only the things that are going through are getting are processing and working against that figure, right? But once you go back and work your denials, that speed of successful submission is actually going to rise, right? So then if the number is too low, you'd think a super low number there would be great, but there's a number there that's too low that tells you this person is not working their denials, right? So if it's 1, 2, 3 days, 4 days on the speed of successful submission, that's too low, because when things deny, you're gonna have to go research them. You're gonna have to go, and that's gonna count against the number. And so that's gonna raise that number. Now, you don't want it to be 30 days. You don't want it to be out there, but there is a nice little sweet spot there that means that you're working your denials and doing so in a timely manner. Okay.
Excellent. Thank you, Shane. All right, so I put up a poll a few minutes ago, and thank you everybody for participating. It is a ranking of interest in what you'd like to hear about. And I think we've got the two biggest winners for extremely interested are around codes, so ICD-10s, diagnoses, modifiers, and claim submission rules, LCDs, NCDs, CCIs, and so on. So Shane, between those two, which one would you like to dig into first?
Give them to me again. Which one? What do we got?
The codes, ICD-10, diagnoses, modifiers, and so on, or the claim submission rules, LCDs, NCDs, CCIs, and so
Let's
on.
do the first one. Let's do the.
Okay.
Yeah.
All right. All right. So codes, diagnoses, and modifiers. So these are things that change fairly regularly. I think in general, if you could, let's set the stage on what are billing codes, what is ICD-10, and then we'll dive a little deeper.
And we'll get and some of this audience was here for the last one, so we'll keep that high level and get to a little deeper level if we can. And so the CPTs, current procedure terminologies, that's what you do, right? ICD-10, that's why you did it, right? And so they have to match. This is not rocket science, right? And so you don't want a broken toe for an upset stomach, right? For treating that. So they have to match. You don't want a retinal diagnosis for a corneal procedure. And so there are guidelines. That sounds simple enough, right? And so for the most part in billing and coding and billing, right? If the doctor follows their education, it's going to make sense, right? Generally speaking, it's going to make sense. If they're obviously the doctor is not going to put a corneal diagnosis for a retinal procedure on purpose. But doctors are people too. Go figure. They have blood running through their brains, and they make mistakes just like everybody else. And so sometimes they maybe link it incorrectly. There are things of that nature, right? But then there are also I don't want to say semantics, but the level of specificity on these diagnosis codes. They may want it drilled down to a higher digit, a higher level of specificity, and that's generally where the doctors may make a mistake. They may put something as a not otherwise specified NOS, and the guidelines for the payer requires that it be drilled down a little further. So you got procedure codes, you got diagnosis codes, the ICD-10 codes, and then the modifiers. And the modifiers are a two-digit code that accompany the procedure code that give greater detail about what was done, but don't change the actual meaning of the procedure itself. So there's a number of different modifiers. We can talk about them if y'all would like. But that's the case there. Modifiers describe the services performed without changing the meaning of the procedure itself.
Can you give a quick example of a common modifier that the ECPs here would see?
Sure. Yeah. You're going to have the most common, I would say, would be
Jennifer suggests it's 54.
54. So 54, that's a good one. So 54, 55, that's going to be on a cataract surgery, right? And so I'll give you let me kind of back up just a little bit. On the procedure codes, you have, this will help with the 5455 discussion there, Jennifer. So procedure codes, you have the technical and professional component of a procedure, right? Did you run it? Did you interpret it? And if you did both of those things, you don't put a modifier. You get paid for both of them. They assume you interpreted it and you ran it and interpreted it, right? So there's modifiers that indicate that. TC is technical component. And what is the professional component? Of course, I'm drawing a blank here. But there's a modifier that means professional component. So 5455 is the cataract surgery and the 55 is the post-op care, right? And so if the cataract surgeon doesn't indicate that they sent out the post-op care, they don't put a 54, they don't put anything, right? Then they're saying we did both the surgery itself and we're responsible for the post-op care. All right, so let's say they do that. They bill out the claim, they don't put a modifier on it. And now it's your turn. You did do the post-op care. You go send the claim and you put your 55 modifier. Well, it'll deny as a duplicate. We've already paid for that. We've already paid the cataract surgeon for it. So those cataract surgeries can be difficult to get paid because the post-op care, because you could do everything right. And if the cataract surgeon didn't, if their billing team didn't submit the claim, if they put the wrong modifier or didn't put a modifier at all, then it'll mess up what you have to do. So a 59 modifier is a common one. And so it means separate and distinct on procedures. 26, there you go. And so, hey, Hunter, Dr. Edwards, good to see you, man. So the yeah, so you have a 59 modifier means separate and distinct. So if you had procedure codes that needed to be distinguished from one another, bypass the CCI, there's another code, correct coding initiative, then that would be one for that. Yeah.
Excellent. Fantastic. And then so that covers codes. Let me go back to the other thing. So there's so codes, ICD-10s, diagnoses, modifiers. We covered that. And those of you in the audience, once again, I want to invite you to ask more specific questions either in the chat or via email if you got them. And then Shane, let's dive into claim submission rules, LCDs, NCDs, CCIs. You mentioned them a couple of times when you were going through codes and modifiers and so on.
Yeah, so the LCDs and NCDs. The LCDs are local coverage determination, right? And NCD, national coverage determination. And so you can go to CMS, you can Google CMS LCD and for your region. So, and then you'll get the rules that come up that CMS is put in place to dictate the frequency of testing. Okay. The frequency of testing, what diagnosis code drives what test, all of those things. Right. And in this scenario, there's two sets of rules. There's the local and the national. And you would think the national overrules the local, but that's not, like the Supreme Court overrules all the baby courts, right? And so you would think the national would overrule the local. It's not that way. It's the opposite. The local supersedes the national. So in the absence of a local rule, you go to the national. But when both exist, you go to your local rule. So these are rules out there that a lot of businesses will sell you access to, but you don't need to. Just pull up the web and Google LCD for whatever Medicare region you're in. And yeah, you'll find a link. You can go there. After going through a couple of pages, you'll be able to enter in a CPT code, and then it'll tell you how frequently those tests are allowed, and what diagnosis codes. Okay.
Excellent. Okay, so we had a follow-up question. Can we specify what the abbreviations themselves mean? So LCDs are local
Coverage determination. Yeah, go ahead, Steve.
local coverage determination. NCD, national coverage determination.
Yeah.
and local supersedes national where there is a local.
Yeah. That's right. Where there is a local.
Correct. And then CCI stands for Correct Coding Initiative.
That's right. Yes.
What is,
And
what is the
correct
Correct
coding
Coding
initiative.
Initiative?
Yeah, the correct coding initiative, the CCI, are a set of rules that kind of govern how these procedures work together, right? And so the most common example in our discipline, in our vertical, is the fact that you can't do OCTs and fundus photography on the same day with the same diagnosis. So most people in this chat probably know that, and they know that those codes don't work together. Now this is a point that is a bit controversial, right? But that's why we're here. We're here to talk, not to avoid topics that are a bit controversial. So let me just lay it out there for you. So there's, and I'm not a doctor, right? I'm just an insurance nerd. But I'm gonna tell you the rules. You can, and if there's ODs amongst us, they can maybe chime in and give us their opinion. That'd be great. But so the correct coding initiative, there are column 1 and column 2 codes, right? That's how these codes work together. Some codes are never allowed to be built together. Those are column 1 codes, right? And so if they're column 1, then there's never a reason to do those two things together. Then there are column 2 codes, right? And so an OCT and fundus photography are column 2, which means there are occasions that they are allowed to be billed together. And you can do so if they're for different reasons, and you bypass the rule by using a modifier. Okay. Now this is a statement of fact. It's not an opinion. What I've just said is a statement of fact. The opinion, and I don't have the competency to tell you, I'm not a doctor, right? I can't tell you this. Medical necessity is not something I can speak to. I can tell you that the rules allow for this. Now, when it really is legit to do those two things together, what diagnosis codes allow for that, that's not my place to say. I just know that the rule is a column 2 rule, and it can be bypassed by using a modifier. So it's up to the doctor to determine whether it's medical necessity or not. And some people believe that this is a loophole, that this is a caveat that isn't meant to be used. I don't get that. They wouldn't have made it a column 2 if it wasn't meant to be done together at some point. I'm just not the person to tell you when that point is, right? But they are allowed to be done on the same day with a different diagnosis code.
Well, I think it actually speaks to a really important point that you've touched on a couple of times through this conversation and previous ones that we've had, is that it's impossible for anyone to know everything, all of the implications, all of the various rules, any edge cases where something might apply. So leveraging expertise where you can will simplify your process. I think there's a lot of industry knowledge that says, figure it out yourself, be independent, stay independent. But, a one business owner cannot be all things in all situations. It's impossible. So leverage expertise where you can, and take advantage of things like this, and being here, everybody. Thank you for paying attention. Thank you for asking your great questions, and your participation makes this a lot more engaging and a lot more useful. We can go over general terms, but seeing what you're interested in, and hearing how we can helps us make a better product and be of more service to you. So thank you. Shane, we've got a couple more questions. Starting with Marcy. What about coordination of benefits, building medical for exam and routine vision plan for the refraction?
Yeah, great question. So Marcy, that is, let me for the audience describe exactly what it is in our purposes of our conversation. Coordination of benefits. So a lot of times people think of, okay, coordinating benefits between two health insurance plans, a husband and a wife, and they cover each other. Then they're coordinating benefits between the plans. And so, but that's not for purposes of our conversation here tonight, and generally in our discipline and in our vertical. Coordination of benefits means between medical and vision, just as you stated. And so when a health insurance company pays for the health-related portion of an eye exam, but maybe doesn't have a preventative eye exam, it doesn't cover the refraction, and someone has a managed vision care plan that does allow for coordination of benefits. And there are some vision plans that do not allow for coordination of benefits. It's plan specific. So VSP has plans that allow for COB, coordination of benefits, and some plans that don't. Right? But when they do, they will cover the difference in the vision and the medical copay and the refraction. Okay. So you're basically eliminating the difference in the copays between a medical and a vision plan, and then paying for the refraction from the vision plan. Right. This is a really good benefit when someone's price sensitive. There's a test that wants to be run, but they came in, they're like, no, 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 that was my copay. I'm doing this. I'm not doing that. Right. And I know that it is what it is. There are people like that. Right. And so this eliminates that obstacle, or reduces that barrier, that objection. But now that's the positive side of it. The negative side of it, what a pain. These things are a huge pain in the behind to identify and to track. It's not so much a pain to submit, right? Someone out there may be going, no, it's not hard to submit. Yeah, it's not. But when you're let's say you take 100 vision plans, right? 100 patients, and they all have medical and vision, and you need to collect the correct copay at the time of service, is when you should be doing it, obviously, right? And so you don't want to over collect. Right. So if you collect the medical copay, let's say it's 30, and you should have collected the vision copay because the COB, now you got a $20 refund to do. And once it processes, you have to know, okay, when the medical processes and it doesn't pay, oh, this is one of those plans. You need a trigger to then go submit the vision plan. So, it's a pain in the behind to do. And I've managed a practice before, and I did both ways. I didn't do it, I did it, incentivized the staff to keep track of it. And other than that barrier, as far as people having objections about increased copays, I found it financially a wash for the business, with how much money had to be spent to track it. Okay.
All right. Thank you, Shane. So, Marcy, hope that answers that question. We've got a little bit of a follow-up on modifiers. So, Dr. Edwards says, how often does that get denied with the appropriate modifier? And then I think it's related to the OCT and retinal photos. And then Jennifer suggested, so an OCT of ONH, which I think is optic nerve hypoplasia, for glaucoma, and an OCT, or maybe optic nerve head, and then OCT of the macula for drusen. So those would be separate things that you could potentially bill at the same time.
I don't know. So, the CCI, the Correct Coding Initiative, is for OCTs and fundus photography. I'm not even sure that those two codes would be subject to the CCI, to be honest with you. So these would be different OCT codes, and I'm not sure that they would be subject to that CCI. I'd have to go check. The modifier for, say, one of these and fundus photography would be 59. It'd be a 59 modifier, and you'd put that on the second code, which probably would be the fundus photography. Okay. And how often does it deny, Dr. Edwards? I don't have the figure off the top of my bald head. I'd have to go look. Yeah. But we can go find out. We can certainly find out. We can write a rule in our scrubber, in our workflow denial tool. Right.
Excellent. Yeah. So always a way to solve that problem. Another question from the audience: a patient with Humana Medicare Vision using iMed for billing. Can you bill Humana directly and prevent iMed from keeping their 40% admin fee?
It was Humana Medicare Vision using iMed for using an iMed policy. They have a Medicare Advantage plan, and they have iMed. Can you bill Humana and prevent IMED from keeping their 40% admin fee. You lost me on that last bit, Wayne. Maybe you can educate us. It's not that it's not a good question. You're just smarter than me, I think. But can you build
If I'm reading
Medicare
this right,
Advantage?
I think the general policy is that you if for a standard exam you bill the vision plan first, right? But I think what Wayne is asking is if they have an IMED plan, can you bill Humana directly without having to bill IMED first? Wayne, please chime in if I misrepresented your question.
Well, I think if the IMED would be for preventative, and they've carved out that preventative eye exam, and the Medicare Advantage plan probably doesn't have a preventative in that scenario, then you'd have to bill if it was a preventative eye exam, then there's no coverage. Now, if it was a health related, a lot of people do with Medicare is the health related portion has a diagnosis. At that point in life, you got something going on, and the health related portion gets billed out as an office visit essentially, and then the refraction is a private transaction between the patient and the whether you agree with that or not, that's just how a lot of people do it. Yep. Yeah, Wayne's teaching us something, I think. So we can get more details. Wayne, thank you for the info.
Yeah, Wayne, if you could reach out after or via email, Shane at anagram.care or Steve at anagram.care, and happy to have that conversation. Would love to dig into the specifics. Um, all right. We are coming up at the hour. Again, I want to thank everybody for your participation, for your fantastic questions. Shane, thank you for sharing your expertise here.
I went
Is
quick.
there, so we have set a goal to do this at least once a month. So if you guys are interested in coming back and hanging out with us again next month, do let us know. We'll send out email invitations as they come through. As we get closer to the holidays, it'll be more difficult around Thanksgiving and so on. But we love that enthusiastic response. Thank you so much.
Wonderful.
If you have questions, if you guys have any ideas, anything you'd like us to cover, please do let us know. These sessions get better with your participation, both during the event and with helping us understand what it makes sense for us to cover. I think what we keep learning is there's so much to know and so little time. So if we can consolidate information in a way that is digestible and understandable to make you better billers, then we'll have done our jobs.
Absolutely. And just let me say thank you to the audience. When we have these, it is a conversation, and it is so much better that way. And so, yeah, as long as the audience is and our friends here are getting something out of this, I'd love to keep doing it, Steve, to the point where we've shared everything. So I appreciate it, everyone. Thank you so much.
Excellent. Everybody, thank you so much for being here. We will, and those of you, everybody who's here is registered. This has been recorded, so you'll receive the recording so you can review it and follow up. If you have any questions, hit us up at goanagram.com. Also valuable if you guys are interested in YouTube, subscribe to our YouTube channel because all of this will go up there for you as well, and in short form and all of our other video educational content. And then we also have a podcast. Envision Magazine hosts Best Practices. We release a new episode every other month, and you can look for it at wherever you get your podcasts, Spotify, Apple Music, whatever. We feature some of the brightest minds and best ideas in eye care to highlight other ways you can improve your practice. Our focus is certainly on the insurance side, but if you find value in what we do here, we would appreciate you subscribing and talking to us, following us on Facebook and LinkedIn and so on. And yeah, the podcast is called Best Practices. If you go to envisionmag.com or find our channel on YouTube, find the Anagram channel on YouTube and just subscribe there because the videos go up there also.
Wonderful.
All right. Thank you so much, everybody. Have a great night. We
Thank
will see you
y'all.
next month.
Thank y'all. Take care.